So good evening, everybody. A very, very warm welcome to IMechE. We're really delighted that so many of you can come along this evening. Thank you for bearing with us. A special thank you already to our speakers who have really come across at breakneck speed in order to get here in time. So we thought it was worth just giving them 2 minutes to catch their breath before we kick off events this evening. Hopefully some of you will have already been downstairs and have already seen the innovation showcase that's down there. If you haven't, fear not. It will still be there later on when we have the opportunity for networking over drinks and refreshments. So we can look forward to that later on. But for now, let's crack on. I have to do the routine announcement. There is no planned fire escape. Fire drill, so if you do hear the fire alarm, please exit through the main doors, turn left down towards cockpit steps. There are a number of members of staff I can see in the hall this evening, so we can direct people as needed. Very good. So hopefully you're familiar with this title. Hopefully you're here at the right event. I'm very, very excited to hear about this report, the role of engineering to deliver a net zero health service. And we're really delighted that we've got Dr. Helen Meese here, the chair of our Biomedical division, and running her own engineering consultancy, the Care Machine, and she's also recently, congratulations Helen, been appointed as the Royal Society Entrepreneur in Residence at Durham University. I'm not going to take any more of your thunder, Helen, because we are going to be hearing from you shortly, but just an observation. Hopefully, many of you in the room caught the fact that we published a high-level strategy last year. It's very, very simple. It says we just do 2 things. We develop and support engineers to be able to operate at their best, and we draw on their skills and expertise to have the maximum positive impact on society. And when we were thinking about this, engineering is one of those things, right? It's everywhere. And we thought, in order to channel our efforts, it would be helpful to identify some priorities for those areas of policy advice. And we identified sustainability and net zero, future transport, healthcare and infectious disease control, and education. So this evening, dear guests, we are hitting 2 of our top policy priorities. So we're really, really delighted by that. Every time I come up here to give an introduction, I learn something. This evening, I learnt that if the health sector were a country, it would be the 5th largest emitter in the world, which is quite a staggering statistic, I think. Clearly, engineering will be at the heart of all our future efforts to improve that situation and track towards net zero. But there will certainly be some challenges along the way, and I'm really looking forward to hear Helen I highlight for us some of those challenges as articulated in the report. But before we get there, to set the context, I'm delighted that we are joined by Dr. Mary De Silva, who is Deputy Chief Scientific Advisor at the Department of Health and Social Care, and also the head of the science and engineering profession in the Department of Health and Social Care. And after we hear from Mary, we are further delighted to hear from Dr. Sofia Lentsos, who is the head of Climate, Health and Sustainability for NHR. And before joining NHR, she was trained as a NIHR. And before joining NIHR, she trained as a medical doctor and worked as an anaesthetist. I always struggle with that word. I still Excellent. So thank you, Mary. Thank you, Sophia. I will invite Mary to the stage first, and then we will hand on to Helen for some highlights before Helen convenes a broader panel discussion later on. Mary.
Great. Oh, a real pleasure to be here. As you've heard, I am head of the science and engineering profession. I'm a scientist by background, and we don't actually have very many health engineers in the Department of Health, which, as identified in this report, is a problem. So I'm glad that people are thinking about that, and certainly having a chief engineer of the NHS is something that is a very interesting idea and one that I would very much support. So We're going to give a bit of background. Sophia and I are a bit of a double act. Sophia is the real expert in this area, but I'm going to give an overview of the work that NIHR is doing broadly in climate and health and sustainability, with a particular focus on healthcare. And the reason why we want to set the broader picture is because net zero is everybody's problem and it's every sector's problem. So today we're focusing on health and care, but actually there are multiple other aspects of climate change which impact on health. And the stronger capacity we have in the research community and the engineering community to deal with the problem of net zero as it relates to human health, the better chance we'll have of decarbonising the health and care system as well. I also just wanted to make a few reflections based on the introduction. So the science and engineering profession has exactly the same goals as you've published in your strategic report, which is to support the science and engineers we have in the civil service to be their best and to make sure that the policies we have in government are informed by the best science and engineering advice. So I think they're very similar goals. And I think the other thing to say as well as another hat I have is I'm head of the health protection research. So I'm actually in charge of pandemic preparedness research and development across government. And so I very much look forward to engaging with this organisation on that as well. Okay, on to today's issue. So I won't go into detail at all about this diagram. It's really just to remind you what you all know, which is this is a complex systems problem. One of the reasons I love engineers is because you're so good at understanding and changing complex systems. Scientists are quite bad at this. They think X equals Y, and it doesn't, and they think that single interventions have an actual single measurable impact within a complex system, which engineers know it doesn't. So one of the key things I'm trying to do as head of profession is to bring that systems thinking into the civil service much more robustly, because practically none of the problems that we have in social care are simple problems that can be solved by a randomised controlled trial. So, and this is also to remind me that there are many unintended consequences of action. So, for example, we know that closed ventilation systems are great for energy efficiency. They might be absolutely appalling for infection prevention control. So understanding the consequences of our interventions within that complex system is critical. I don't need to preach converted about the importance of research and innovation in climate and health. We know it's a fast evolving agenda. We need a much better evidence base than we do already. And there are huge research gaps which we need to address, not only in data, but also in which interventions are most effective and how those interventions work together within that complex system. There's also a real need for a multidisciplinary approach so that we can generate policy and practice relevant evidence. And I'm quite new to government. I've spent most of my career in academia and recently at the Wellcome Trust. And it's much harder in government when you have to make decisions and trade-offs. And again, scientific evidence tends to give us an answer. And actually what policymakers want are the trade-offs. So we want to know if we're going to decide to put in a particular intervention for net zero, what impact does that have on health? How much will it cost? Will it drive economic growth? What will be the impact on net zero? And it's very difficult at the moment to understand those different competing trade-offs of individual interventions. And that is actually the information that policymakers need. So I think the academic and scientific and innovation community needs to get better at measuring multiple impacts or multiple outcomes of the interventions. Again, if you're thinking in a systems way, that comes naturally. So NIHR has an agreed approach to climate and health and sustainability research, and we've actually published these commitments for the next 2 years very recently, and Sophia leads on all of this work. So the 4 big things that we want to achieve are reducing the operational carbon footprint of the National Institutes of Health and Care Research through more sustainable procurement, through ensuring our policies protect biodiversity, and obviously reducing carbon in all of our activities. Moving to the far right, funding research is obviously the core business of NIHR, and we want to fund research in 3 main areas: health and care systems, research systems, and human health. And we'll talk in more detail about that in this presentation. We need to have better training and capacity building, and that includes bringing in engineers and increasing the multidisciplinary teams that we fund. And lastly, there's no point in generating all of this evidence if we don't mobilise it. So maximising the evidence that we do have, particularly within the policy-making environment. And as I say, these are now published on our website with detailed commitments on what NIHR will do to achieve them in the next 2 years. In terms of the research funding then that NIHR is putting in, one of the key recommendations from this report is more research funding in this space, and we are absolutely aiming to deliver that. And this year we have announced 2 substantial new funding schemes, both of which we are absolutely pleading for engineers to apply for. So I'm going to talk a little bit about human health, and then Sophia's going to talk about health and care systems and research systems. So these are the 3 goals we're aiming to achieve with our research funding. In terms of human health, we want to protect the population's health against the impact of climate change and to realise the health benefits of a net zero transition. So we need to be mindful that when we're putting in net zero interventions like electric cars or sustainable heating systems, for example, we do understand and measure the impact that that could have on human health, and we make sure that those interventions are designed to maximise population health and not have detrimental unintended effects. So for human health then, I won't go through all of this detail, but we have multiple funding avenues, particularly health protection research units, which are centres of excellence with multidisciplinary teams in health protection research. They're being recommissioned at the moment, and we're specifically commissioning a climate and health environmental change health protection research unit. And this is a group of interdisciplinary researchers who can do quite agile research in response to policymakers' needs, right at the interface with evidence and policy. We also have a new joint call, so a £30 million investment across UKRI and NIHR, which has already been released and the preliminary applications are in. So I hope some people have applied, because what we're looking for is interdisciplinary teams, ideally including engineers, to address, basically to achieve the goal of supporting the UK to achieve our 2030 net zero goals while protecting and promoting the health of the UK population. So really understanding what are the health impacts of interventions in a number of key areas. So we've got particular focuses on indoor environments in a net zero world, on greener transportation, sustainable healthy diets, extreme heat, and finally, but really importantly for this audience, decarbonising patient care pathways. And we aim to fund in each of those challenge areas at least one large interdisciplinary multi-year consortium. So 7 years, £7-8 million to get an interdisciplinary consortium together to really tackle that problem. I'm now going to hand over to Sophia to talk about the other 2 areas of research.
Thanks, Mary. So as Mary said, I'm going to talk a little bit more focused on the other 2 pillars of our research funding scheme, so the health and care systems and the research systems. And the first thing I would say with the health and care systems, when we talk about this in the context of NIHR, we are meaning both the sort of decarbonisation aspect, but also the resilience aspect. We know that healthcare systems are already feeling the impacts of climate change. There were theatre cancellations last year with the heat waves when IT systems went down. I won't focus it on this call. I will focus particularly on the decarbonisation, but not to say that that is something that we're not thinking about. So I'm sure everyone here is familiar with this diagram, a very common thing to present in a talk around decarbonising the NHS. So the NHS is responsible for 4% of the UK carbon emissions. We've heard the stat already around healthcare if it was a country, but the 4% of the UK emissions is the equivalent to the entire country of Croatia as well. So a really significant amount that we're talking about. The NHS was also the first healthcare system in the world to announce net zero ambitions. And now I think it's over 60 countries have also committed to net zero and decarbonisation targets. But I think the important thing to say here is that people are still looking to the UK on how to achieve some of these goals. And so there's a real opportunity for us to be world leaders or continue to be world leaders in doing this agenda. And I think there's a real opportunity here to share that good practice and learning internationally as well. The other thing to say is that it's now also in the Health and Care Act, there's legislative responsibility for us to address this. So this is a waterfall chart that's taken from the Net Zero report, and it essentially takes the emissions that those areas seen in the previous diagram, those known target areas, if we reduce them, where we'd actually get to in terms of net zero. And I just want to highlight the one that I've boxed in at the end there, which is just nebulously labelled research, innovation and offsetting, which accounts almost for 22% of the carbon footprint, but is also the we don't know how to do the rest of it. So there are significant research gaps, not only in what we already know where to target and how to target them and how to actually implement them, but also in the things that we don't know how to do yet. So there's a real need for new innovation in this space and new research. Talk about catching breath, I still haven't caught mine. So again, I'm not going to go into too much detail, but just to talk about some of the things that we are doing in NIHR, particularly around decarbonising and sustainable NHS and health and care systems. So in COP 2026, we announced a funding call, a themed call on sustainability, where we funded a £2 million net zero surgery programme through Birmingham. I think you may have seen them in the news, having delivered the first net zero operation. There's also the new call that Mary's talked about, and I'll talk about that in a little bit more detail after this. There's a particular call that we've got around building the resilience of the healthcare system, but particularly around innovation, we've done a couple of things. Our Invention for Innovation programme, we've done a pilot, which was a fast programme, so it was looking at those particular blockers, and it was a 6 to 12 month turnaround time, and it was just funding specific projects to sort of get over an initial hurdle in their innovation. And we funded a couple of sustainability projects through that. And we've also partnered with Zinc Venture Capital to sort of build these innovation fellowships in health and care. And they have got a pillar around climate and health, and those applications are closing, I think, next weekend. So we're really excited to see what some of those innovation fellowships come out of that. So this is the new call that we've got. It's a £25 million funding call. It's an annual call over the next 5 years with £5 million available each year. And this is going to be open across all of our programmes of research, including our innovation programme. And the reason we've done it over 5 years is we really want to build this community. We really want people to know that there is opportunities for funding coming in the next sort of 5 years continually. It will be open every November in line with COP. We're doing quite an open, like a long lead-up time at the moment, because we really want to engage people and make sure that people are aware of it. We're getting those connections. We're going to do a lot of support with this workshop. So we're sort of hosting webinars, workshops to try and bring those interdisciplinary teams together and give those the opportunity to meet and engage and network to then put in successful bids. Apologies. I think it's really important. The other thing I want to say is that with NIHR, we sometimes have a very select, there's a subset of people that we often, who know about NIHR, who know that we exist, and who often apply to us. And I think Mary's already said about this intersector working. It's really important that we start expanding our reach and who can think to apply to NIHR for funding, and we just want to sort of acknowledge that actually this is a really wide problem, and we really want to bring in people that don't normally look to NIHR for funding to say that actually there is a health outcome as a core foundation of whatever you're looking at, particularly around decarbonisation, that this is an important area and we are open to those collaborations across different sectors. The other really important aspect is research systems. Now, we know that research and innovation has its own footprint and environmental impact, but we're probably behind the curve in understanding what that actually means, particularly even behind the curve for healthcare. But there is a lot of momentum building in this area, and some of you might be familiar with some of these innovations and these things going on at the moment already. So there's been a lot of work, particularly around sustainable laboratories, but there's also increasingly more work going on around clinical trials, and we funded some work around lower carbon clinical trials as well. But there's still a big unknown question, so we're still grappling as a funder and as a sector what this means for research and what we need to do moving forward as well. So we have got some specific funding around actually understanding the sustainability of the research system. I said we've already funded some work on lower carbon clinical trials, understanding what those carbon hotspots are and actually how we mitigate those. Across all of our NIHR funded pieces of work, whether it's about sustainability or not, researchers have the opportunity to apply for what we call a study within a project. And this is essentially additional funding that is looking at a specific methodological intervention aimed at reducing the environmental impact of their research. And the idea is that we start building an evidence-based repository of actions that people can take in their research, in their innovation, that actually reduces the footprint but doesn't compromise on the research integrity. The other big thing that some of you may have heard of is UKRI, Wellcome, and other funders have been working on this Concordat for environmental sustainability of the research and innovation system. And this is a cross-research system agreement, which essentially sets out the minimum set of standards for research funders, academics, and also the institutions themselves about what they can do to start helping embed environmental sustainability. And I think this report is hopefully coming out at the end of the month, and NIHR will be an early signatory of this report. So looking to the future, as Mary said, we are actively looking, and we have actively committed to increasing funding across all of these areas. We do have some work already ongoing, and we really hope that the current funding will start to be able to inform policy and practice in these areas. But we know that there's still significant research gaps. We know that there's still a lot to do. And we know that this is still quite a new community. And so we really need to start building that capacity as well. I think it's already highlighted in the report that was shared as well, that sharing learning and case studies is a really vital aspect of this. And I think that connection and those cross-sector networks and partnerships to share learning and case studies is a really important thing to do as well. And then just those last 2 points, one of the things that we are starting to grapple with is that we also need to start looking at the environmental impact of the sort of the interventions, the actual, sorry, my words have gone completely, the actual environmental impact is a core outcome of research. We know that if we're looking to embed something within the health and social care system, it's aiming to be net zero. And if we're not actually starting to think about that intervention in the context of net zero and what that impact will have, then 10, 15 years down the line when that's part of practice, we're going to need to start thinking about it anyway. So we need to start thinking about it as a core outcome of research. And I think there's still a lot of unknown questions on how we achieve that. So we know we're asking a lot from researchers and innovators. We're asking you to identify what needs doing and prioritize it and have the right expertise in that group to design it. If you're an innovator in a business with part of the NHS Sustainable Procurement Network and their sort of roadmap to net zero, you need to also understand how to operate your business in a sustainable way and think about how you design your product in a sustainable way. And we're asking you to measure the impact of your business, and we'll be asking you to measure the impact of your product, service, or innovation as well. So there's a lot that we're asking. So really, as a funder, we're constantly thinking what we can do to support people in each of those areas. So in terms of the what, we can work with partners, we can highlight evidence gaps, we can do prioritization work, and we can put those on our website and share those learnings to sort of say, these are what we're interested in. We can facilitate these workshops and these matchmaking activities, particularly across sectors, and bring people together and get those right people and right expertise in the room. We can understand what evidence you need to answer those unknown questions, particularly around regulation and working with MHRA and understanding what their blockers are and what the evidence gaps are needed for them to be able to move things along. And we can work with other partners with the NHS to make sure that our SMEs are supported when there are changes to procurement guidance. We know where to signpost people as well. And in terms of impact and measuring, we need to develop support and guidance documents for people to be able to use and to be able to consider the environmental impact. And I think the really important thing here is that we're working across other sectors and other funders to make sure that there's consistency across the system, because we don't want people having to do different things for different people. So I think just to highlight the opportunities, and I think a lot of these are overlaps with the opportunities and things that are identified in the report. There's real learning to be had from industry and the private sector, and how can we bring this into the equation? And I think that really also speaks to these cross-sector networks and partnerships. That's also networks and partnerships with industry and the private sector as well. This multidisciplinary working, which I think is a key theme whenever we talk about this, and also international learning. And I think that reciprocal learning, yes, we are the first healthcare system to do this, but there's now a sort of healthy competition between healthcare systems to try and get ahead of the curve. So where can we also share that learning? Learning and case studies, I think, is a really important thing. And I think data is fundamental to a lot of what we're asking, and consistency of data. And so I think if we can build and collaborate, having these open access data repositories where people can go for standardized data sets that we understand and everyone's using and everyone's singing from the same hymn sheet on, that I think will go some way to helping this agenda forward. So, insert inspirational quote here, but I think the main thing is that these kinds of events are really important. I think it's fantastic that we're actually starting to see more and more of these sort of engineers and environmental scientists and behavioural scientists and health economics and health researchers all coming together to actually recognise that they do need to work together on this agenda. And I think it's about reframing health at the heart of this. I think that diagram that Mary showed, where it has all the different upstream and downstream effects and the pressure on the healthcare service, we understand that we're not going to do this. One sector is not going to solve net zero in isolation, and all of this will have an impact. And that systems approach, those cross-sector networks, are really vital for this moving forward. So I think this is a fantastic opportunity to start working together. Thank you very much.
That's a hard one to follow. You can just give me a second for me to get my notes. Thank you, Mary and Sophia, for that opening address. There are many things that you've said. I was nodding profusely as you were speaking, but I really do appreciate that you have come today to present. So thank you very much. I don't know what's happened here, but we'll put this back to where it was. And so please bear with me a second. I should have set this up, but I nearly ran out of batteries before I even started. So thank you for your patience. Well, good evening, everyone, and thank you so much for being here tonight. It's a real pleasure to see so many of you here, and I know that there's quite a few people who weren't able to attend, and we're hoping that by recording this event as well, we will be able to spread the word among the community further. As I've already said, thank you very much, Mary and Sophia, and also thank you to Alice for her opening comments. I do appreciate that the CEO of our institution is a very busy lady, and I really appreciate her time here tonight with us, so thank you. It would also be rather remiss of me to not mention a couple of members of the team as well. The dedication and skills of Dr. Laura Kent, who is part of our very talented policy team here at the institution, and also William Rowe, who is not actually an employee of our institution, but has been on loan to us from across the road, and has recently returned back to his post. The two of them have put an awful lot of effort into this report, and I could not have done it without them, so thank you to the pair of them. I'm extremely pleased to be presenting the findings of this report tonight, which has been a subject that has been very close to my heart for many years now, and will continue to be so in my role as entrepreneur in residence at Durham. The report focuses on sustainability and net zero in healthcare, the impact climate change in particular is having on global health, and the vicious cycle that the healthcare sector has found itself in and is perpetuating as a result of very well-meaning technology, innovation and medical advancements. I will, of course, be looking at this through the lens of engineering, and we'll highlight what the engineering community is and could do to break the circle and create care solutions for the future that are environmentally, socially and financially sustainable. I will also outline the recommendations of the report and present a call to arms, not just for you here tonight, but engineers, medtech companies and governments across the world who have the opportunity to change the direction of planetary events and the way that we care for society. But first, I'd like to share with you a short video. This is one of several made by Maria Kojic, I think it's pronounced. She is an ex-nurse and an artist from Denmark. And she has had personal experience of clinical care, which has inspired this particular visual piece. It's about a minute long, so. Well, could we have some sound, please? I think that you will all agree that whether you work in the healthcare sector or not, that is a profoundly impactful video that has a real impact on your view of medical waste when you see just how much is used in one single operation. I'd like you to bear in mind as well that throughout the UK, there are well over 1 million surgical procedures carried out each year. Some relatively small, some much bigger than the one in the film, but all of them are unwittingly contributing to continued environmental damage. Because despite the all-consuming mission of the global healthcare sector to do no harm and protect society from illness, disease and death, it is, according to the NGO Healthcare Without Harm, as Alice said earlier, the 5th largest emitter of global greenhouse gases on the planet. That puts us somewhere between Russia and Japan in comparable emissions. And indeed, the healthcare climate footprint is estimated to be around 4.4 of global net emissions, and that's the equivalent, for the engineers in the room, of 514 coal-fired power stations. I'm hoping I'm pressing that way. And it makes a significant issue, and it's just as vitally important as the issues associated with the waste in the food sector, which is also something that the Institution of Mechanical Engineers has been acutely aware of for many years. So it seems ludicrous then really to think that through the act of caring for those suffering from health conditions brought about by environmental pressures, it is both directly and indirectly partially responsible for their conditions in the first place. And I think Jackie Daniel, who is the past CEO of Newcastle upon Tyne Foundation Trust, put it very succinctly when she said, "There is no health without a sustainable climate." So what are these emissions that are being produced by the healthcare sector, and why are they causing so much impact? Well, obviously, being the engineer that I am going to be embellishing this talk with a fair few statistics to hopefully try and answer this particular question. Evidence shows that more than 70% of carbon emissions in healthcare are derived from manufacture, transport and disposal of goods and services, food and agriculture supplies, medical devices, and hospital equipment and consumables disposal, with energy consumption in healthcare facilities adding a further 12%, and operational emissions and emergency vehicles accounting for 17% of the carbon footprint. And this doesn't include the emissions from visitor and patient travel to and from appointments and treatments. And this is somewhat difficult for us to measure, but it's safe to say that it's somewhere in the tens, if not hundreds, of kilograms of CO2 per person per day. It's quite clear then that the healthcare sector, both clinical and technological, must address their alarming contribution to the climate crisis in two ways. Firstly, by finding more effective ways to treat those who are ill, injured or dying from environmental impacts. And secondly, by drastically changing the way healthcare services are delivered. So let's look at the relationship between climate change and health. In the sixth assessment report of the Intergovernmental Panel on Climate Change, this is the IPCC, they stated that human activities have undeniably caused global warming. The World Health Authority set about trying to define this and the impact of climate change on health into four broad categories. Direct impact from extreme events, indirect impact from ecosystems such as undernutrition or dehydration, changes in vector-borne disease transmission, and indirect impact via socio-economic systems, such as things like increased poverty and mass migration. So to put this into simple terms, changes in our climate are expected to cause approximately 250,000 global additional deaths per year between 2030 and 2050 as a result of these four categories. So if we take the instance of air pollution, for example, this will result in significant numbers of asthma cases and chronic obstructive pulmonary disease, leading to a decrease in population activity and thus to things like early onset cardiovascular disease. But what of health care itself? Well, again, who has categorised these into six significant contributors? General waste is a fairly obvious one, but that doesn't just include the surgical waste we saw in the video. It's often made up of single-use items, but it also includes e-waste, the electronic devices that reach the end of life or are just discarded because something more innovative comes along. Wastewater is not just generated through the care of patients, but also through activities in the supply chain, such as during manufacturing and from poorly managed runoff into rivers and oceans. By way of another statistic, in 2021, when delivering patient care, the NHS hospital staff used 10 times more water than the average office worker, at an annual cost to the taxpayer of £60 million. The global transportation of procured goods, direct energy use in healthcare facilities, and patient and staff travel all contribute to general emissions, producing millions of tonnes of carbon dioxide each year. And while in the West we consider our management of things like toxic chemicals and pharmaceuticals to be one of the highest in terms of standards, there are many countries who do not take this approach and continue to process large amounts of hazardous chemicals, particularly during the manufacture and disposal of medical technology and equipment. And we often forget the impact of indirect resource consumption, such as that used in the production of healthcare consumables. For example, take disposable cotton materials. It's used in everything from surgical gowns right through to swabs. It has a significant embedded environmental impact due to the fact that cotton is a highly water-intensive crop production. So we can safely say then that we have brought ourselves really to the precipice by our overwhelming desire to keep people alive. Now, I'm sorry that I've depressed you with my first 17 slides. But let's take some time to look at some of the more recent achievements that have really begun to address some of these challenges. And for this, I wanted to focus on the NHS in particular. The report is very much focused on that, but take this as an opportunity to think about some of the global impacts that we have achieved already. We are extremely privileged in the UK to have probably the world's greatest public health provision. Not just because it's rather unique point of care service model, but as a result of the significant investment into life-changing technologies and medicines that has been undertaken over many decades, alongside academia and industry, to create what is a unique service today. Technical and clinical advancements and innovations have become ubiquitous in our everyday care. And disease and disabilities once considered impossible 75 years ago are now run-of-the-mill in many treatments that clinicians undertake. The paradox is that for the NHS, that while it provides over 7% of the UK's GDP, buying in goods and services from over 80,000 different suppliers, it accounts for around 4% of our country's carbon emissions. And in line with the global figures, it is used everywhere, this image. More than half of the NHS emissions, that's around 62%, are linked to its supply chain and procurement of goods, such as medicines and equipment, while 14% of its emissions are linked to things like travel. This would ordinarily seem like an insurmountable challenge for a national health provider on top of all the other challenges that it has to face. But in 2020, the NHS decided to draw a line in the sand and set a goal to become the first healthcare provider in the world to commit to delivering a net zero service by 2040 through its Greener NHS initiative. To achieve this, it not only had to challenge the way it cared for patients across the hospital network by opting to use more sustainable methods of treatment, but it also had to radically transform the way it selected and used products and services, driving change across its entire supply chain. The Greener NHS team at that time was led by Dr. Nick Watts, and Nick believed that by building pride in the organisation's achievements and taking bold but achievable action, the NHS could reach the standards of the Paris Climate Agreement and could, in turn, see over 5,700 lives saved from improved air quality alone, with some 38,000 lives saved from a more physically active population, and over 100,000 lives saved from healthier diets each year. So, 3 years on from that goal setting, have they made an impact, or has this been yet another environmental white elephant? Well, I think for many of us in this room, we know that it has been a success, and what they have achieved so far has been not short of outstanding, really. The NHS as an organisation and its staff have wholeheartedly adopted the initiative, which has now become embedded across every aspect of care, from simple reuse, reduce, recycle programmes, right through to entire hospitals' NOx cylinder manifolds being completely decommissioned. They've achieved this by enabling staff and management to prioritise issues relevant to them, manage the task at hand without being overwhelmed by stats and KPIs, while seeking support from other hospitals or agencies on how to address their specific problems. By structuring the mission in this way, they have been able to maintain impetus and demonstrate impact and outcomes that can be clearly seen by governments and patients alike. And I thought I would, at this point, just share with you a couple of my favourite projects and their outcomes, just as a taster of what can be achieved with simple and yet clear goals. The first actually was touched on in the opening address. This is the University Hospital Birmingham, who have demonstrated the ability to create a completely net zero operating theatre. They have managed to save about 80% of what would have been the carbon output. And that's apparently the equivalent of a car travelling 5,500 miles. What stood out for me was that not just the reusing of gowns and drapes and looking at ways to recycle single-use equipment, but one of the consultant surgeons actually jogged to the hospital on that first day, and the other cycled. So they were very committed to what they were trying to achieve. Catalytic converters you would normally associate, certainly in a mechanical engineering institution, with vehicles. However, using these kinds of technologies has been very successful in reducing NOx emissions. NOx, for those of you who aren't aware, is 300 times more damaging to the environment than carbon dioxide. And we use tons of the stuff across healthcare. St George's Hospital has invested in a catalytic converter which has been able to reduce the gas down to harmless oxygen and nitrogen gases and has eliminated 99% of the nitrous oxide that is released into the environment, and also that was affecting the exposure of staff as well to this particular gas. So it's saved on the staff health as well as the patient health. And if you haven't already been downstairs to see some of the amazing initiatives that we have on show, I do encourage you to go down after the panel session to have a look at some of the incredible technology that's on display. But how will the greener NHS affect the upstream supply chain, and how will the NHS maintain such a massive programme of change? Well, for this to be achieved, the NHS requires a supply chain which believes in and is committed to the same sustainable principles and goals as they are. And it needs to be, with that in mind, the NHS has put a programme in place outlining what the medtech businesses should be doing between now and 2030. They have even created a handy tool called the Evergreen Sustainability Suppliers Assessment, which will help suppliers and manufacturers prepare for this. So far, I've talked predominantly about the impact of the climate crisis, the role of healthcare providers, and the challenges faced by society. But what of engineers and the engineering community, those both within the NHS and in industry? What part are they going to play in all of this, and what are they already doing to implement and maintain these changes for the long term? Well, like clinical professionals, engineers have the power of life and death in their hands. And just like clinicians, chartered professional engineers also have a Hippocratic oath in the form of their codes of conduct. In it, we agree to not compromise the welfare, health and safety of society and to safeguard the public interest. In more recent years, our accreditation body, the Engineering Council, has recognised that beyond the basic requirements of our professional obligations, we must be especially aware of our impact on the world around us, that we justify our actions for the greater good, and we speak openly and honestly with those around us outside of our profession. It seems obvious then, to me certainly, that engineers would want to play a leading role in the implementation of sustainable and net zero initiatives within healthcare, the healthcare sector. And certainly none of the examples that I've shared with you this evening, or those that appear in the report, would have happened without their involvement. Engineers and engineering will ultimately drive the development and adoption of sustainable and green technology alternatives going forward, and will be the linchpin that ensures the longevity of sustainable change, particularly in the NHS. And I would like to just pause for a second to acknowledge the more than 3,000 clinical engineers and their colleagues in medical physics and estate services, without whom the NHS would not function. And I'd also equally like to thank Rachel Stancliffe from the Centre for Sustainable Healthcare for her acknowledgement of engineers' impact in the foreword to our report. But for the engineering community, we cannot do this alone, and I am pleased to say that that was a comment that was also echoed by Sophia. This is the motivations are really based on this in the report. We wanted to highlight the successes to date and the incredible people who are implementing change around the world. But there is still so much to do. And our 5 recommendations outline not insignificant tasks that are ahead of us, and how we are going to achieve this to transition to a net zero healthcare service really is going to be an uphill struggle, but I do believe that we can achieve it. UK industry and academia has always punched above its weight when it comes to technology innovation in healthcare, but there is still a need to create a concerted effort to encourage and support the development of solutions to achieve our net zero aspirations, which could be accomplished through the creation and implementation of a centralised knowledge hub to facilitate the seamless exchange of information and best practice between hospitals and industry. We also have a duty to ensure that the medtech businesses many of us work in are aware of and prepare themselves for the sustainability requirements needed by healthcare providers. And to ensure that, we need to create and allow them to have a voice to ensure that when it comes to decision making, engineers are at the forefront of those processes. There remains a significant issue for the NHS which has yet to be addressed, and that's workforce. There is simply not enough engineers working directly in the NHS to sustain these changes in the long term, and certainly not enough engineers across the whole of the sector in general. We have an opportunity to encourage more engineers to take up engineering and technical roles in the NHS and medtech industries, to not only increase engagement with their clinical colleagues, but also to help patients, carers, and the general public understand how they are benefiting from medical devices, as well as responding to concerns that society might have about the greener care pathways. And while industry will be in a position to produce innovative technology needs and address environmental events going forward, the implementation of effective monitoring of processes and supply chain activity has a huge question mark hanging over it. Regular assessment, audits and report obligations will go a long way to addressing this, But we do need to ensure that the whole supply chain can benefit from compliancy, not just the big players in the market. We must nurture accountability, even in the smallest businesses, to guarantee the resilience of our medtech industry in the future. And lastly, we need to increase the pressure on governments across the world to create a more coherent strategies that link health and climate change, and which will support the uptake of sustainable technology by providers and patients alike. The world's and the global impact of climate change is undeniable. At the Lancet Countdown report for 2021, they stated that the world is not on track to realise the health gains of a transition to a low-carbon economy. Air pollution, infectious diseases, poor food quality, weather, energy, transport, and really an over-reliance on unsustainable supply chains are just the tip of an extremely large iceberg, which the global healthcare sector is facing. Engineers are playing a significant part in many of these healthcare issues, both directly and indirectly, but this is often hampered by a lack of foresight and long-term strategic planning from global governments and the immense challenges of societal inequalities. So if we are to answer Maria Kojic's question of, is there another way? My answer is yes, absolutely there is. But for the global healthcare community to reduce its carbon footprint in the next decade and beyond, then sustainable health technologies, innovation, and investment and awareness must be at the forefront of every nation's climate change policy to address the unhealthy mess that we currently find ourselves in. And I would just like to finally thank all of the people who contributed to the writing of this report and to the IMechE for hosting this launch event. And I really do appreciate that you sitting very still while I talked for far longer than I intended to. But thank you very much. If you would like to speak to Laura or any of the policy affairs team, Laura's information is up there. And if you would like to talk to me further, there's my QR code as well, if you would like to use that. But now I'm very excited to have other people talk about this incredible issue. And we're going to have our panel session now. And I hope that you have many questions to ask them this evening as well. I'm checking on my time. So I'm going to invite them very quickly to the stage. I know that Mary and Sophia, that you're going to stay at the front here, aren't you, together, but you are willing to answer a few questions if those come up. I appreciate that. Ioma, there she is. Would you like to come and take a seat? You are the Education Fellow at the Centre for Sustainable Healthcare, who I mentioned, Rachel earlier, who is the CEO of the organisation and has been very supportive of the work that we've done. Addie, if you would like to join us. Addie is Sustainability Manager at the Association of British Healthcare Industries, and we're very pleased to have them here representing the medtech companies across the UK. Joseph, hi. We haven't had a chance to say hello yet, but Joseph is Sustainable Transformation Project Lead at the University College London Hospital's NHS Foundation Trust. And finally, Fanny. Fanny Burrows is the NHS Research and Innovation Lead at Greener NHS, NHS England. And finally, Paul White. Paul is a consultant clinical scientist and head of clinical engineering at Cambridge University Hospital Trust, Foundation Trust. Thank you, all of you, for sitting so patiently. I'm sure you're itching to answer questions and maybe ask questions of our audience. I don't know. I'd like to just start really by getting your thoughts on the report, and I want you to be honest and open. This is not, a great plug and say how marvellous it is. What were the standout things in the report for you, if you've had time to read it, that you think are things that we as an institution and the engineers should be taking forward? I'm going to start from there.
I think for me, my background is I'm a medical doctor, so I think to see the emphasis on the need for collaboration between engineers and doctors, I think we can identify sometimes what frustrates us within the health system, where there are opportunities to work more sustainably, but we may not necessarily know or have access to the solutions. And I think it sounds an awful lot like you guys do, and seeing all the things that are on show in the showcase downstairs definitely represents that.
Yeah, I would agree with that. Addie, would you like to add to that?
I'm going to sound quite boring and almost echo the same thing. I think part of the fact that this paper was written in the first place is a huge step in the fact that it's recognising the role and how broad the ecosystem is that needs to get involved in order to make healthcare net zero, to reach those targets. So I think it's, highlighting where the need is and also how we can address it.
The biggest one for me is about bringing the innovation that engineers can take into the NHS very closely. And I'll use a live example to try and demonstrate that. So at University College Hospital, we've recently had some heat decarbonisation plans done. And they identify to us that the biggest thing that we can do is to get an air source heat pump amongst other energy efficiencies. Now that's great, but we're a central London hospital with a roof that is full of cooling equipment, that has got charity roof gardens, that have got planning constraints that were put in place to actually allow those things to be there. So it's all well and good for us to have a report that says, hey, this is great, but actually it's going to need some really novel, innovative thinking to actually put that in place. And I think the real role of engineers in the kind of work that we do is actually coming up with some of these novel solutions and putting them into practice.
I would have agreed strongly on the collaboration, really sort of emphasizing on the cross-sector sort of multidisciplinary collaborations. But I think I'm going to focus on the workforce. And we do a lot of work within Green NHS on the workforce, supporting those initiatives that are coming from the workforce itself. And I think there's a huge potential to see to find opportunities and to share learnings across the workforce between, the sort of clinicians, the engineers, the sort of sustainability staff, the sort of management, to all come together and have strong leadership to sort of push those initiatives further.
It's interesting and it's great that clinical engineering is at the forefront, and I think it had to take a pandemic for that to happen. So it's great. So collaboration is really, really key. One of the other issues is that we can't continue as we are. Innovation needs to be at the forefront of what we do, and with innovation is transformation. It is around transforming the multidisciplinary team. As Professor of Clinical Engineering in Cambridge, I sort of work very closely with multidisciplinary teams to identify those unmet clinical needs. So that's, I think the report brings it out very nicely.
Thank you. I'm going to open to the floor. We have some roving mics, so we'll be able to hear you. But would anybody like to ask our panel some questions, or indeed myself and some of the team? I can see Peter's hand has gone straight up. Peter, if you'd introduce yourself as well.
Yes, Peter Flynn. I'm a past president of the institution, and I seem to have a role asking first questions in these lectures to get things moving. I had two questions really, sort of related to each other. The first one is you've identified the scale of the task, and you've talked in terms of 4% of the UK's emissions, coming from the health service and so on. In terms of actually taking that down as close as possible to zero, how much of that relies on new technologies or things that aren't known at this stage? And how much of it is, if you like, organisation and getting deployment of things that we already at least partly understand? And then the second related question was you did refer to Scope 3 emissions, which are outside the direct control of the health service. I didn't quite pick up what percentage of the total of that 4% came from that source. But whatever it is, how are you going to tackle that particular issue?
May I just answer the latter part? We don't really have much of an idea of how much there actually is. We've got some understanding in the UK because the NHS are very good at measuring things, but it's very difficult to know what that third part actually is. But I'm going to open up the questions, but I'm also going to look to you two at the front as well, because I don't know whether there's some responses. Who would like to tackle that question?
I think on the operational one, largely my role is trying to do those sorts of things and actually getting them into practice. There are lots of things that we have and that a lot of hospitals haven't yet done or in the process of doing. And a lot of the time that's simply because there's the classic NHS, there isn't enough time or there isn't enough capacity or there isn't enough money. And a lot of things, we know how to do them, we just haven't done it yet. I think to the first one, there's lots of things that we still don't know. I think particularly when it comes to sort of certain types of equipment that we use, can we make it reusable? Can we remanufacture it? Now, there's loads of things coming through the pipeline on that, and hospitals are starting to introduce them. But those sorts of R&D, when I speak to suppliers who are doing a lot of things in the medtech space, 3 years, 5 years, they're thinking about it, but it's not quite there yet. So actually saying how much of that stuff is still to come is a really difficult question. And I think also to go to the point I made in my opening, even some of the technologies we do have or know how they work don't necessarily fit the complexities of the NHS estate. The NHS estate is often old, it's not always in the best condition, and sometimes it's got huge numbers of competing priorities on it. So to actually try and retrofit buildings like that is really, really difficult, and is going to require, as I said, some really innovative thinking on how we take technologies we've already got and make them actually apply to the estate that we have.
That's a good point. Would anybody else like to?
Sophia's one of her slides, she had the pathway which outlines what the significance of research and innovation and the unknown is as well. So we could see in that slide, in the grey wedge, how significant it is that we do have to invest in innovation, but it does also say all the other things that we can try and do.
Just to come in from the industry point of view, so all the things that you said, I think, when similar to how it's so difficult to retrofit hospitals, it's also really difficult to redesign medical devices once they're already in practice. And so that's a massive role of engineers, is there's things that we can do with the devices that we already have, but also from now on making sure that what we're designing has circularity in mind, what you're doing with the product at end of life, all those sorts of things. I think in terms of remanufacturing and reprocessing, there are some examples of where it's done really, really well. And already are in place, in particular things like surgical instruments and the big MRI machines and the things that are maintained for a long time. But there are a number of barriers as to why there are some products that aren't being used in that way now. And so I think it's a part answer and there's lots of reasons, but industry are working really hard in trying to think about what is happening with those products at end of life and how we can keep them in the system. So it's kind of lots of moving parts.
Linked to that is the whole regulatory element, and we need to work with the MHRA much closer. And that is some of the barriers in the new MDR that's actually been written. There is a chapter on sustainability, but it's actually trying to get to the root of the cause and the practice of what's going on, looking at clinical pathways. How can we work in the NHS with academia and the NHS together? No one single entity can actually do it. If manufacturers think they can do it, it's about designing devices for clinical need, taking into account sustainability. So I think it is a multi-centered approach, but a lot of it also sits around the regulatory framework.
And I guess,
could you lean forward a little bit?
Whilst I look after a lot of initiatives around innovation, we also need to look at what we can do from an intervention perspective. So yes, innovation, yes, technology, but we're not just talking about product. We're talking about, moving from surgery that take and sort of hospital stay that are patients staying for 3-4 days to actually day case that has a huge impact on our carbon emissions. So we're talking about innovative approaches, I think, as well as innovative products, and that's something to keep in mind. On innovative technologies and products, we also need to make sure that we don't just push innovation and technology, we need to understand their impact. Yes, they might solve the solution of a problem here and there, but what are the impact on the care pathway? We're talking a lot about digital technologies. What is the impact of digital technology from a carbon and energy perspective? So all those things need to be considered as a kind of a wholesome approach when we're thinking about innovation and technologies.
Mary and Sophia, would you like to say anything on that as well? Laura, could you provide a microphone, please? Thank you.
Thank you. I mean, I so agree with everything you've said, and it just reminds me of my day-to-day work, which is how do you get innovation in the NHS? How do you get the evidence that we know in any field into the NHS? And it reminds me why partnership is so important, because there are lots of things which solve problems, but those problems aren't the big problems that the NHS needs solving. And unless we work together with the people who know what the problems are and what solutions would actually be scalable and sustainable in different contexts, we're not going to get to a suite of solutions which actually work.
Yeah, I think everything's been said already, but I think just coming back to sort of what are the numbers, we don't know the numbers. I mean, that waterfall chart does some way to sort of showcase some of those things, and sort of 22-ish% is the research innovation. We don't know what's next, which goes to say sort of almost 80% we know what to do, but it's not that straightforward. We've already heard that there's gaps in evidence on how we actually implement the things that we do know work and what technology already exists and how we actually implement it into a health system. So I think it's not quite that straightforward. And I think just to echo Fanny's point, that it's really important that new invention, new products, new services do start taking into account the actual environmental impact of the actual product service itself and that wider context in the NHS, because I think, we just need to start thinking about that as a core outcome with things moving forward as well.
Yeah, I would summarise that in terms of saying that this is a system of systems problem, Peter, that at any point, if we modify or change something, we're going to affect change somewhere else, for good or bad. So there's an awful lot for all of us to do, to work together to understand how those systems of systems are constructed so that we can deal with that 20% that we don't know much about. Thank you for your question. Yes, please.
Thank you. It's Mike Ralph. What am I? I'm head of energy for NHS Scotland Ashore. Sorry, I've recently changed my jobs. It's an observation and a question to the panel. I mean, about 2003, Mike Arrowsmith, who'd been previous chief engineer of NHS estates, he gave a lecture and he said that was healthcare sustainable? Was it sustainable? And he sort of gave a lot of things, and there's a lot of things that changed, but that very sort of visual thing about the breast operation, it shows that there's still so much stuff which for infection control and prevention is single use and throwaway, and still the question is there, does it really need to be? And after having sort of just come through some fun times at the Scottish Hospital inquiry, it's that same thing. It's the service, safety, risk and reliability and how you balance that out. So a lot of the things on sustainability is versus sort of your infection control protocols and your safety protocols. And how do we get that sort of, that balance?
Yeah. Mike, I think that's a really interesting question. And if you're of a certain age, what goes around comes around. And I think... in the 80s and 90s, we moved more to consumable items in trust, and I think that was a phenomenally moving video to show what the impact is to the environment. And I think we need to go back. We need to relook. We took out sterilisation plants out of hospitals because we didn't think we needed them. We thought we could go for single use. Single use was the way to go. And I think we now need to sort of reverse engineer where we are currently and actually look at, was that the right decision at that time? Do we need to reintroduce this? Because if we're going to look at reprocessing of devices, reprocessing of consumables, not only is the regulatory element that we need to look at and how we might deem those still to be appropriate to meet the requirements, specification requirements of those devices when they were new, they've now been reprocessed. Should certain agencies do that? Should manufacturers do that? All those questions need to be looked at. But I think we need to go back to the fundamental. Should we be reusing reusable technologies going forward?
I think that's a very good point, and I'd like to ask the rest of the panel. It's very easy for us as engineers to say, yes, we can make a solution to that, whatever it is. We'll do it. But we have to really be asking the question, do we need to make change for change's sake? What are your thoughts on this particular question? You know, we now seem to be going full circle back to using, you know, washable gowns and things like that. And so we need to build, you know, our laundry facilities back into hospitals. What are your thoughts on going back to these older ways, shall we say, of doing things?
I think the thing that I would add to your point is that the use of an IPC team as a blocker is often used as a blocker that doesn't actually need to be there, in the sense that IPC team that I engage, when I engage them regularly, because every change that we bring through like this needs to have their approval, they're actually very on side. An IPC team generally sees the kind of things that goes through a hospital, sees waste and knows efficiency. And there are those who perhaps want an easy route out, and I've heard it termed yellow washing, which is actually, I want to use this as a blocker. And in other hospitals I've engaged with about some of the sustainability projects that we've managed to get going, their IPC team have come down with not necessarily the strongest level of evidence and said, no, that's not the case for all. And I think one of the benefits of actually having some sort of national policy on things like this is that it gets rid of some of that ambiguity. One of the things about hospital trusts is they all have their own infection prevention and control teams, which is the right thing because they know their organisations. But actually not having those kind of national guidance and national guidelines means that those things are open to interpretation. And that can make things very difficult. But actually having that kind of level of consistency, particularly when it comes to sort of reusable products, would make the kind of work that we're trying to do a heck of a lot easier.
I think you make a very good point there, Joseph. Could we? Yeah.
What comes to mind is two things for me. So one thing is that I work in sexual health, and there's this discussion about whether we go back to reusable speculums. And the first thing is that people automatically are like, oh no one would ever want that, patients would hate it. And now actually people have done research and they're like, well, if you're saying it's good for the environment, then yeah, we'll think about it. But there is that point that was raised further down that there needs to be sterilisation available, decontamination available, and if you're in a community clinic, that's not an option. So firstly, it's not a one solution will fit all. The second thing is also, I think, research and education. So being able to prove to people that, hey, if we do this and we're reusing it, actually we don't see any worse patient outcomes, that's ultimately what all healthcare professionals want to see, that we're not doing any harm. But it is also an education thing. So we, at the Centre for Sustainable Healthcare, we work with NHS trusts and we do this thing called Green Teams competition. So we have done one with an infection prevention control team. And because of COVID, people are using PPE inappropriately and they're not necessarily aware of when they should and shouldn't be using it. So the IPC team put together a campaign. This was trust-wide, and they were able to reduce the amount of gloves and aprons and things that they were using. So it's two things. It's not just about you guys and innovating, it's also educating people within the healthcare system as well, because although, yes, we have made lots of strides, there is still a lot of people who aren't aware of this net zero agenda.
Thank you.
I want to talk about a bit of work coming from the Department of Health and Social Care called Design for Life Collaborative, and that's specifically looking at resource efficiency and resilience, but in turn the circular economy for medical devices. And as part of that work, a lot of the things that have been touched on the panel are being looked into. So it launched last, I think it was March 23, and it's ongoing, and these challenges are of size, and that's why it's going to take quite a long time. But it's things like the infrastructure and moving back to how, in essence, how things were. And one of the main streams of work is looking at what the capacity is in the UK, what we have in the healthcare system, what we have in the private sector, what we can utilise, and then also looking at the workforce to support that, because it's all well and good to build all this capacity, but if you've got no one to work in it, what's the point? And another aspect of that is the behaviour change as well, thinking about, there is, I think, an assumption, as you say, that that level of PPE does need to be used, and it's kind of legacy thinking from the pandemic and thinking about what actually is the level of safety that's needed. As part of this collaborative, it's a huge amount of industry, it's the healthcare system, it's government, it's trying to get all of the players in the same room to figure out how we can collaborate and work together on these things. So the hope is that from that piece of work in particular, some of the things that have been spoken about on the panel will be solved or be supported or be funded or be researched. But it's just a big area, in all honesty, so it's going to take some time.
Yeah, but the paradox is we build bigger hospitals because we need more beds to treat more people.
that requires more air, more volume, more processes, more stuff. So it's a spiral.
I would.
So it's looking at that.
Yeah.
How do you treat that? Does something need to be that clean? Does it need to be that sterile? Do you need to do this? And that then links into infection control and nosocomial infections.
I think from our perspective, sorry, I feel like this is really loud. We have these 5 principles of sustainable healthcare, and the first 2 are the most powerful, and it's prevention and patient empowerment. So we're building bigger hospitals because people are becoming more and more unwell. Actually, what we need to do is target people not becoming unwell and focus innovation on preventing ill health, empowering our patients to manage their conditions when they can. And then when they do have to come into hospital, making those streamlined pathways that are working most efficiently. So not just the products, but the pathways as well.
Mary, you wanted to add? You said exactly what I was going to say, which is, and this is something that the Department of Health does really care about, and we've got areas of research interest in the Department of Health. All of them are targeted at transforming the NHS to be a health service, not a disease service, to take care out of acute hospitals, to put it into well-being and prevention, because not only is that more cost effective, it's also much better for the planet.
Absolutely funny.
There's also a huge role, we're talking about bigger hospital, but I think there's a real trend on community care after people, but much closer to home. So that's emphasis taken away from the hospital, and I think that there's huge opportunities there.
If I can just add one more thing to that on the point that you're making about prevention, the most sustainable hospital is the one that hasn't got patients in it. So the fewer patients that are actually needing to use a service, the less demand there is on it. So we think through actually what do we do in the hospital, but a lot of this work actually goes further down the stream, as we've discussed here, to actually prevent people getting sick in the first place.
Yeah, I think that's the best quote of the evening. So I'm very keen. We are we've got an hour of networking, but I'll take the last 2 questions, and then if anybody wants to ask questions afterwards of our panel and so on, we can do that over drinks. So I'm going to start with this gentleman there, and then, yeah. Laura, yeah. Sorry, I wondered where you were going.
I'm going to leave this one here.
All right. Thank you.
Thank you. I have a question about education and more so about communication. So, just to give a small background, I have a degree of medical engineering. I have been studying for 10 years, and within 10 years, I have barely spoken to a surgeon, never spoken to a nurse, never spoken to a patient. Most of my education has been theoretical. My practical skills finally started developed when I worked at a medical company. And I faced this difficulty at my end of PhD when I actually had a passion, and now finally I had skills to make something to improve, is I actually didn't know where to go to. The question starts is, are there any networking events where engineers can go to speak to clinicians and where clinicians can come to speak to engineers? Because I was lucky. I had in my PhD at least one surgeon as a supervisor, whilst other students for 4 years did medical research and they have never spoken to any healthcare professional. So where can we network?
I think that's a very good question, and that's the purpose of really what we're trying to do here, not just with this report, but building these communities within the Institution of Mechanical Engineers, the other institutions that are represented here tonight, but also to start this dialogue. I think a lot of young engineers are not getting that exposure that they need, and what we want to do is create opportunities for them to come into the NHS, to come and work in greener NHS, to work as clinical engineers, and all of this, I think, is really the basis of why we're here. As to whether there are any of those opportunities, maybe Sophia has got an answer. I don't know.
I don't have a formal answer, but I'm just saying that I think this is a recognised thing that is starting to take place. So I know University of Southampton and Southampton Hospital have started a Faculty of Medicine Meet the Engineers event every sort of month or so. It's not particularly well attended at the moment, but I think it's just that starting that groundwork of starting those conversations, starting those introductions are happening as well. The other thing I mentioned is that as part of our funding call, we want to start creating some of these spaces and open workshops, and I don't like the word sandpit events, but essentially these opportunities for people to come together to start talking, those conferences, collaborations. I think it is starting, but something maybe more formal might need to take place.
Can I just jump in? I think it's about clinical engineers making opportunities for themselves as well. It's about putting yourself out there. So I work with our management exec team on a routine basis. It has some disadvantages. All my KPIs are seen by management exec. So when I'm not performing, there's an issue. But it's about putting yourself out there, showing what engineers actually can do. It's about taking those systems engineering approaches and looking at those unmet clinical needs. So I have a small team, clinical engineering innovation of 8 people, in addition to the other clinical engineering teams. And it is about taking those unmet clinical needs. It's using Stanford by design processes to identify those technologies and stuff that we can actually take forward. Some of them are processes and process-driven. Some of them might be devices. Some of them actually might be, there are issues and problems. How can we do that? So it's about putting stakeholder groups together, looking at patient and public involvement and integrating that together. There isn't one solution. It's about the clinical engineer facilitating with others the solutions going forwards.
And I think on that as well, the report talks of sort of these kind of sandpit events. And actually, I've seen the benefit of that in real time. So we had a sandpit event that was facilitated by UCL Partners, which is an academic health innovation network. And what that did is we as a hospital went with a live problem. And our live problem was we want to put our theatres into setback mode, essentially sort of turn it off overnight. But what would that do? Does that affect the level of infection prevention through our theatre? How long does it take to come on? Will it actually use more energy powering back up than coming back down? We presented that to a number of academics, admittedly senior academics in the room. And from that, we managed to spin out a whole research proposal, and the paper's about to come out really, really soon. So in that sense, what we did there is probably what needs to happen more, which is actually to bring these live problems to those that have the experience. And they've come visited our hospitals. They've been to hospitals in Europe as well to actually bring some of that best practice back to the UK. So I think the point that you're making is a good one. I think what the report recommends is actually more of these kind of events that will allow people like me and other colleagues to come with live problems that we don't have necessarily the expertise to have, to those that do, that have the live knowledge, that may be able to access the funding streams actually to put this into.
Thank you.
Just one thing I forgot. One thing is that the NHS is very, very good at replicating things. So we do something in Cambridge, somebody else will repeat it in Southampton, somebody will repeat it in Nottingham. We need to get away from this. It's about, so we had a visitation from NHS England's Deputy Chief Scientific Officer just the other day, and Vicky Chalker was saying, who have you spoken to about this? Who have you identified in the system that? How are you publicising something else? And one of the things that we come away with is that we need somehow to have, whether it's a website or whatever it might be, something that's dynamic, that identifies some of the, as you say, some of the problems, and who and what is working on the solutions, and how other people might be able to integrate into those collaborative ventures.
Very quickly, yeah.
The Centre for Sustainable Healthcare has multiple networks, specifically for some specialties, but more generally as well. And they have network events, but it's a way that you can try and link up with people. So if someone is working on a project and they want some sort of input, they will just post, and that's how you make connections. And it also has case studies which people can then adopt. And I think someone said in one of the opening talks that's really key, because not everyone has the time or the capability or the headspace to come up with these things. And so if someone is doing something that's really useful, it should be shared so that it can easily be adopted, because we don't have the time to keep reinventing the wheel.
Yeah, thank you. I'm going to move to the gentleman there. Thank you for your question.
Can you hear me? First, thanks for putting this event on. I think it's great that you're highlighting the role of engineering in transforming net zero in healthcare. So thank you for that. And thank you for the gender balance as well. It's been really refreshing to see that as well. My question really is, so I'm one of the companies downstairs. They're all fabulous companies, but one thing you'll notice is they're all very small companies. our oxygen is funding, and from my perspective, it's very, very difficult in this country, particularly to get funding for innovation when you're a very small company. Now, I was very lucky to get an SBRI Phase 1 grant, really genuinely thankful for that. But subsequent to that, it's been very difficult to get follow-on funding, and I recognise that the IMechE are trying to do something about that. It's slightly disappointing that we've got to wait till November, I have to say, but innovation can't wait, and net zero can't wait. So my question really is there any other way to look at funding streams that we aren't necessarily aware of as small businesses?
Thank you. Sophia, I'm going to ask you to start.
I feel this is targeted at NIHR. So firstly, no, you don't have to wait till November. NIHR operates, we're always open for business. If you have an idea, you don't need to wait for a commissioned themed call for something to apply for it. You just need to, each of our funding programs have their own open dates for their various calls. So the I for I program, who does help with the managing of the SBRI funding, if you go on their webpage, they will say when their calls are open and when their funding committees are open, and you can always put through a good idea. So that's if anyone takes anything, you don't have to wait for a call. Yes, we do recognise that this is an area that needs some work, and so the injection of calls and specific themes is more just to say we are interested and we want more of it, but we absolutely aren't saying that you have to wait for these things to happen. So, we recognise, and there is more to do, and it's not going to be. We're not going to get it completely right, and we are still learning, and we do want to still hear back from people, and we want to hear back when people are struggling to get funding, or there's particular barriers, or whatever that might be. So we do, we want to hear back from people's experiences, and we are constantly wanting to improve the system. But no, absolutely, don't wait till November if you've got a good idea.
Thank you. Addie, I wanted to bring you in on this because, as I understand it, and please correct me if I'm wrong, it's something like 95 or 98% of medtech companies in the UK are SMEs, are small businesses. So we have a responsibility, don't we, to ensure that they have access to that funding, and particularly around sustainability, that they're able to implement these requirements by the NHS, and we need to be able to fund them to do that.
Yeah, absolutely. It's about 90% SME heavy as an industry, which is huge, and it's not comparable in any way to the pharmaceutical industry, and having so many SMEs comes with its own problems. It's a lot more difficult considering how many suppliers there are to talk directly with the NHS about these things. Understandably so, it's capacity. But I think it's making sure that funding is available. Also want to signpost the Health Innovation Networks. I don't know if you're aware of them or work with them, yeah. But I know they've helped a lot of organisations in this space. And yeah, it's just very much worth raising the fact that it is SMEs, and speaking more broadly about sustainability in healthcare and working for an SME organisation, timing and resources and funding are so hard to come by. If you're a company of 10 people just starting out, even just understanding what the requirements are in order to keep up with the NHS supply roadmap is incredibly difficult. And as a small plug, IMechE obviously try and help that an awful lot and provide the resources. But it is just, again, worth mentioning. It is tough and this is challenging, but it is also incredibly important. So,
Fanny, could I bring you in on this question? Because obviously, knowing your, your involvement with SBRI in your previous life and now on what you're doing now, what do you think the NHS's responsibility is to try and help with some of this funding? I know you're loaded with stuff at the moment and money is tight, but how are we going to bring the NHS and the clinical side into the research and development of technology?
Yes, I think it's really difficult. Funding is tight. We wish we could put a lot more funding in this, and we just, it's not that straightforward. And I guess my first thought is to try to sort of connect and sort of use those collaborations and those connections to try to find different opportunities. From an NHS perspective, what we're really trying to do from a sort of reducing our carbon emissions, reducing our footprint, is to try to have more clarity on where those needs are. we need to act now, but we also need to start to put strategies in place where we can start to look at the sort of near and the sort of medium-term future. So trying to understand, what are the innovations that we need? Where is the funding? Where does the funding need to be targeted from an NHS perspective, but also working with our partners nationally and internationally. And again, working really closely with NIHR to sort of start to think about what are those research needs and how we can collaborate to sort of start to get that message of what are those research needs and what we're looking at in the future to fund research and to fund innovation. So we've got a little bit more clarity on what that can look like. And then that allows more clarity to all the partners. That allows clarity to the research funders, to the actual researchers and the academics, but also to those that fund innovations and those innovators themselves to have clarity on what is needed for the future and where is the NHS looking at when we're looking at priorities, when we're looking at funding, and when we're looking at supporting you to get a product or an innovative solution into the system. So I think that's really the message that we're trying to do, working with the different partner, with the sort of clinical team to get an understanding. It's not easy, and we don't know. We know some things, but we don't know everything. At the moment, we're really understanding that we've got high volume care that is really heavy from a carbon footprint perspective. We know about the cross-investigation sort of procedures that we really wanted to sort of start to bring those emissions down. And we're looking at different parts of this high volume area and how we can reduce the carbon emissions. But really looking at, further details and granularity on the delivery of care.
I think that's a really good place to end. I appreciate that we've run over time, but I think what you've said there, Fanny, is it actually brings together many of the questions that we've had this evening, that there is a need for the engineering community to raise its voice, to engage more broadly, to bring this sandpit approach to sustainable problems, and to enable our small businesses and those that are just starting to be able to engage with the NHS in this particular area. So thank you so much to all of you for coming this evening. I appreciate that some of you have come from a long way away. Thank you so much. And thank you very much to our panel of guests who have a plethora of expertise, and we could probably talk all evening on these subjects, but thank you so much. It's been a pleasure to have you, and thank you, Mary and Sophia, for your opening address as well. We will be having drinks and networking downstairs, and please go and see some of the wonderful companies that are downstairs. There's flashing lights and all sorts of things. It's marvellous. So thank you very much for joining us. Thank you. It has been a fantastic evening at the launch of the report. I am so pleased so many people have turned out this evening to come and listen to our keynote speakers and our panel discussion and also my presentation in launching the report. It's just been a wonderful atmosphere, and there are so many people from across the healthcare industry who are here tonight, from small SMEs and companies right through to senior members of the NHS.